Okay, ready. Go.
Okay. So, greetings everyone from Bombay Orthopaedic Society and Wiroc Global. And we are very grateful and very glad that ONLAT can participate in Wiroc Global meeting. And thanks everybody, especially Dr. Daniel Moya and the entire team from ONLAT. To begin with, I'll share my presentation and introduce the meeting to you. This is the Bombay Orthopaedic Society, which is a very old society. We are 56-year-old, and this is the 56th annual conference, which we are calling Wiroc Global. Global because more than 70 societies across the world are participating, and members of all these 70 societies will get access to watch content from each other, and that is the unique part of Wiroc Global. So ONLAT will be viewed by members of more than 70 societies on the Wiroc Global platform. I am the organizing secretary, Dr. Sangeet Gawale is the organizing chairman, and Dr. Vishal is the organizing secretary along with me. It is a physical meeting, 4 days, which is happening in Mumbai, along with the Wiroc Global virtual part, which everybody here is a part of. This is the Bombay Orthopaedic Executive Council who has worked together to bring this huge meeting to us. We again welcome you and thank you for your participation. I'll hand it over now to our moderator, Dr. Daniel Moya, sir. Over to you, sir.
Thank you very much, Ashok. Thank you very much, Dr. Niraj. This is really a pleasure for us to participate in this big meeting. ONLAT is a federation that put together the societies in Spain and Latin America dedicated to the use of shockwaves in musculoskeletal pathology. And we have the experience to work together with the Indian societies and with OrthoTV in the past. I'm very happy about that. So we have organized a program in which we will give you a general idea, a panorama of what we do, which are the indications that we use, and which are the results with the use of shockwaves in different musculoskeletal pathologies. We will begin with Dr. Anunciación Español from Spain. She will give us an introduction about the use of shockwaves and its physics characteristics. Nunci?
It's okay. Good afternoon from Spain. I thank you for the organization to invite me in this webinar. I will take you a little introduction about basic principles of shockwaves applications. I have no interest economics. If you look at the picture on your left, you can see a focal shockwave. It's a single impulse with high peak pressure, very short duration, short recovery, and a small positive recovery wave. It's very different picture on the right, the radial pressure wave that is has long duration and less energy. We have different technology of producing shock waves. There are electromagnetic, electric, and electrohydraulic generation. They made the wave focused in a one point, very different to pneumatic and ballistic radial that spread the wave radially as a hand fan. The devices are also different. In radial pressure wave, we have this one, and all the others are shockwave devices, big and small. Each device has its own focal size, has its own applicator with different focal size, as you can see in this picture. It's very important to know which kind, the characteristics of the devices we are using in order to obtain best results and minimize the side effects. So have physical effects. Direct, like coupling effect, is an interaction of the shock wave with the tissue which has different interfaces and acoustic impedances. The indirect effects of decapitation is the formation of air bubbles within a fluid due to negative pressure and are responsible of the destruction when we use high energy devices and regeneration effects in low energy. To understand the biological effects, we have to know the macrotransduction action. That is the mechanism in which a mechanical impulse into the tissues release growth factors, cytokines, auxin synthase. That is the mechanism that is implicated in the tissue regeneration processes. This biological effect at neoangiogenics increase the regional vascularization in the zone, tissue regeneration, and analgesic effect. In the Conference of ISMST, the International Society of Shockwaves, in July 2017, they reached a consensus about terms and definition and determined that definition of shockwave and radial pressure waves. They made the consensus of indications, contraindications, and recommendations in order to prevent improper treatments. They say also the prerequisites and minimal standards for performing shockwave therapy. After a very good, it's necessary good indication. The indication with indication about after the clinical examination, radiological and scanning imaging. And they determined that only qualified physicians certified by national or international societies may use focused shockwave therapy to treat pathology. For treat bones, we determined that only focused shockwave and high energy should be used with positioning technology like fluoroscopy or ultrasound. In accordance to the scientific evidence, ISMST recommends to use focused generator. You have high energy better for calcification. For superficial devices should be with or without focusing, but make attention to know the depth of penetration of the shock waves when we treat deep tissue structures in order to prevent side effects and complications. This is the approved standard of ISMST. Chronic tendinopathy, like calcifying tendinopathy of the shoulder, lateral epicondylopathy of the elbow, greater trochanter pain syndrome, patellar and Achilles tendinopathy, plantar fasciitis. In the picture on the right, you can see an article published in the Journal Journal in 2018 by Dr. Moya and Dr. Ramon. They chose a level of recommendation using focused shockwave high energy for calcifying tendinopathy of the shoulder. Skin pathology, we can treat non-healing bone, delayed, skin ulcers, and bone bones. In bone, the evidence based in medicine says that it's necessary to use high energy focused shockwave for example, pseudoarthrosis, non-union bones, stress fracture, avascular bone necrosis without articular affection. Other indications are tendinopathies like rotator cuff tendinopathy without calcification, medial epicondylopathy of the elbow, adductor tendinopathy syndrome, pes and serinus tendinopathy and peroneal tendinopathy, and foot and ankle tendinopathy. In bone, bone narrow edema, Osgood-Schlatter, tibial stress syndrome, myofascial syndrome, and cellulitis. Those are the indications reserved for physicians who has long-term experience in treatment of shockwaves. The contraindication, advanced also in a scientific evidence and consensus statement, commonly for radial pressure wave and focused wave waves are the malignant tumor and fetus in the treatment area. If we have malignant tumors not as underlying disease, that is not a contraindication. Reserved for high energy focused waves are the lung tissue, epiphyseal plate, brain on Spain in the treatment area, and severe coagulopathy. It's necessary to localize the treatment area in high energy for bones and calcifying. We use fluoroscopy and ultrasound always. And for tendinopathy and muscle, if we have ultrasound, better, but not necessary because the palpation, the patient feedback can help us. You know, shockwave is transmitted by water, so we need to put gel between the skin and the applicator, avoiding air bubbles in order to avoid loss of energy. The position of the patient, it depends on the pathology. Normally, lying, supine, lateral, prono position, sometimes sitting. In all cases, we have to reach the comfort of the patient and physician. And the physician has to press the applicator gently but firmly onto the skin. In reference to anesthesia, the evidence show less efficacy using anesthesia for tendon, so it's not recommended. Exception, calcifying tendinopathy of the shoulder when you use high energy focused devices, depending on the patient and the tolerance of the patient. In bone, we use always regional or general anesthesia. Secondary effects are very rare. Its recommendations and follow-up are described especially for high energy focused shockwaves. Tendon rupture when you use energy flux density over 0.6, bone osteonecrosis, visceral injuries like pneumothorax, kidney, intestine, neurovascular injuries. Sometimes it's very important for physicians to know that I said before what kind of device we have, and they follow the instructions strictly. Science usually transient some limited mild, like increase of pain, dysesthesia, petechial erythema, reddening, hematomas. It's very important to explain to the patient that extracorporeal shockwave therapy biology, it needs time. It's not an immediate functional rest is permitted. It's necessary after the session. For tendons, stretching, eccentric training, avoid overload during 4 to 8 weeks. It's possible some maximal training, rehabilitation. In bone, we have to follow the basic principles of acute fracture after the treatment. Very important also is to give a informed consent and to respect the legal effects. This is our informed consent approved by ONLAT and CETOC. And finally, I will invite you to the next Congress of CETOC ONLAT and the IST research meeting that will take place in March in Madrid. You are invited. Thank you very much.
Thank you very much, Enunci. Now we will move ahead and we will have a lecture coincidentally from the organizer of that meeting in Madrid, Dr. Karen Freytag. She will speak about plantar fasciitis, that it is a very common indication for the use of shockwaves. Karen, if you want to share your screen.
Thank you very much. Thank you for your invitation. I am very glad to share with you my presentation, plantar fasciitis. Do you see my screen?
We can see it very well. It is perfect.
Fantastic, fantastic. So as Dr. Anunciación told us, plantar fasciitis is the most common cause of calcaneal heel spur. I cannot pass my presentation. Let me see why I cannot.
Just press Siguiente.
Siguiente. Siguiente. Just press here en siguiente. A ver. Siguiente.
Tienes
Sí,
abierta una ventana blanca que dices, y el primer ítem es siguiente, ahí.
Sí. A ver. I cannot give to the next slide, sorry. Siguiente. I don't know why I cannot give it to my next slide. I will try it again. Control remoto. Sorry.
Trata de salir de la presentación y vuelve a entrar, Karin.
Vale. Espera. Es que no sé por qué no me da.
Karin, lo que puede pasar es que no estés compartiendo la pantalla que quieres, o sea, el archivo que quieres, de repente estás compartiendo otro. Sal y vuelve a entrar para compartir la pantalla.
O sea, el uso compartido de pantalla. A ver, es que mi ratón deja de compartir. Now I'm sharing it again, ¿ok? Compartir pantalla.
Y ya no toques más, y ya solamente avanza con la flecha. Una vez que compartas pantalla, avanza con la flecha, pero
Vale.
todavía no compartes.
O sea, no doy a compartir.
Comparte la pantalla, como antes, exactamente igual.
Vale,
ahí está.
Ahora ya estoy.
Perfecto. Bueno, avanza con la flecha. A ver si puedes avanzar, no con el mouse.
Okay, thank you very much. Now we are,
Perfecto.
Sorry, I have no conflict of interest, of course. So the definition of plantar fasciitis is the most common cause of subcalcaneal heel pain. It's had a prevalence of 10% over the world's population. And we have principal risk factor, intrinsic risk factors, and extrinsic risk factors. The intrinsic risk factors are related to anatomic risk factors like pes planus, cavus overpronated, excessive lateral tibial torsion, adversion, overpronation, and of course, overweight. Functional risks to do with tightness or weakness of gastrocnemius, soleus, and foot muscles, and degenerative risk with aging of the heel, fat pad atrophy, and stiffness of the plantar fascia. Extrinsic factors has to do with overuse, incorrect training, inadequate footwear. So we have pain with the first steps in the morning or after prolonged sitting. It's a sharp pain. I palpated the medial calcaneal region, and we have discomfort by passive ankle first to dorsiflexion. Plantar fasciitis could be bilateral in 30%. Ultrasound is a good image to make the diagnosis. Thickening up of 4 millimeters of the plantar fascia. As a diagnosis, we can find also areas of hypoechogenicity, and this traduces the alteration of the plantar fascia. We can do also X-ray, very important to inform the patient that the score has nothing to do with the pain. It is not correlated with the symptoms. And if we have a prolonged and refractory pain, we should do MRI so that we can detect tumors or other bone pathologies. The differential diagnosis is very important so that we are successful with our treatment. So we should do differential diagnosis with Achilles Tendinopathy, stress fractures, ruptures of the plantar fascia, medial nerve entrapment if the patient refers dysesthesias in the foot, plantar fibromatosis, this is Ledder-Hose disease, tumors, and of course, other systemic diseases like diabetes, rheumatic, autoimmune, vascular and neurologic diseases. And you all know about the conservative treatments we have used before, drugs, instrumental treatments, physical treatments, and new emergency techniques like PRP, local injection of botulinum toxin, and the last step should be, of course, surgery. But this was the first important study published in 2006 by the group of Kollwitzer and Ludger Gerdersmeyer. They proved that focused extracorporeal shockwave treatment in plantar fasciitis has a 50 to 65% of success. This was very important. And the reviews of all meta-analyses concerning randomized controlled trials are positive in relation to pain and functionality. We can make a good approach with only one session of shockwave therapy, but normally the next slides that I'm going to show you is the comparison between shockwave therapies with other treatments like PRP and conventional treatments. This is a randomized trial showing that there is no great difference between PRP and shockwave treatment in terms of FAS and of a scale. But if we compare shockwave therapy with injections of botulinum toxin, shockwave therapy is superior to botulinum toxin injection in plantar fasciitis. And in this study from Saxena and also Kollwitzer, comparing shockwave to placebo and endoscopic plantar fasciotomy in a group of athletes, of course, shockwave treatment could be preferable since the athlete can remain active during treatment. And to corticoid injection, we all know that corticoid is a good tool, but only short time lasting. So we should use other options. Radial pressure waves are also a good treatment in plantar fasciitis. This is a level of evidence one study from Ludger Gerdersmeyer. He can show that radial pressure therapy improves pain, function, and quality of life compared with a placebo group. And if we compare with other treatments like orthotic treatments or low-level laser therapy versus radial pressure waves, we see that all are effective and no superior. It depends which kind of patient are we treating and which are the demands of the patient, and of course, which is the economy of the patient. And radial versus ultrasound significantly is for radial treatment more effective than ultrasound therapy. And versus corticosteroid, as I meant before, radial therapy has a longer duration of action and no side effect, of course. And if we compare with radiofrequency thermal lesioning, we should consider that shockwave therapy is less invasive than radiofrequency thermal lesioning. But the effectiveness of different treatment modalities like PRP, prolotherapy, the conclusion is that shockwave therapies are effective in the first 6 months, but we cannot find great difference among these 4 treatments in a long follow-up as 36 months follow-up. So the conclusion is shockwave therapy is a good tool, but not in a long-term follow-up. This is the studies of high level of evidence. And if we compare radial versus focus with functional measures, the conclusion from Heinz Lohrer is that focus extracorporeal shockwave therapy may be superior compared to radial pressure waves. And this was also demonstrated by Wang recently, that focus seems to be more effective than the radial pressure waves, always speaking about plantar fasciitis, and that the medium energy group had better success rates. Our recommended protocol for focus shockwave therapy treating plantar fasciitis is 1 to 3 treatments, energy flux density between 0.2 to 0.3 millijoules per millimeter square in an interval of 1 to 2 weeks, impulses between 1,500 and 2,500 in a frequency between 3 to 5 hertz, and localization, inline ultrasound, offline ultrasound, or clinical feedback. And for radial pressure wave therapy, from 2 to 5 treatments, energy maximum 5 bars, frequency between 6 to 10 hertz, and impulses between 2,000 and 3,000 also could be assisted by clinical biofeedback or ultrasound. As predictive factors, we have a positive predictive factor if we found edema around the plantar fascia and in the bone, in the calcaneal bone. And the improvement of the clinical criteria are related with the decrease in the thickness of plantar fascia. Now we have a new emergency tool, elastography. Elastography evaluation can be useful to monitor the efficacy of the treatment, providing quantitative data for us. And as Dr. Asuncion told us, no complication at all with our shockwave therapy, plantar fasciitis. In this study with 2,493 patients from Radial, they only reported pain in a minor number, 225 patients, and only transient red skin in 247 patients. So we can see that shockwave therapy is likely a safe treatment for plantar fasciitis. So these are our message so that you can take them home. No local anesthesia. Persistence of heel spur should be informed to the patient, and no strenuous activities during therapy 4 to 6 weeks after. Please take care of sports modification. Stretching exercises are very important during treatment and of course after, and we should do a follow-up after 1 month. So you are all invited to our setup congress, also ONLAT Congress, and we are going to meet with the research group. This is very important for us. They are opening new fields in shockwave therapy. So thank you very much for your attention.
Thank you very much, Karen. Now we will move ahead to Dr. Paul Teran from Ecuador. He will speak about a very sometimes tricky condition that is the patellar tendinopathy. Thank you for joining us, Paul.
Thank you very much. Please confirm me if you can hear me.
We can hear you and we can see your screen very well.
Oh, thank you very much. Oh, hello, everyone, and thank you very much to join us, and thank you for the invitation to my college and teachers. Our topic today will be talk about patellar tendinopathy. My name is Paul Teran, and I have no conflict of interest to give this conference. We belong to ONLAT, and the objective of this lecture is talk about this important tendon like the patellar tendon. It's a much powerful tendon in the human body, and it's important to remember that the physiological range of elastic capacity of the tendon is around 5%. Over 5% have a chance of generating microscopic damage, but more than 8% of its elastic capacity of the tendon can break. Thus is a first cause. Higher the load, greater probability of damage. But the tendinopathies have a stage of production. In the first level is the injury produced by repetitive activity, previous traumatic injuries, chemical products, or pathologies that damage the tendon. At the next level, in the stage 2, there is a failure in the healing process determined by two large groups of intrinsic or extrinsic factors to reach stage 3, where the clinical manifestations are characterized by pain, weakness, or rupture appears. Here we can see a normal tendon, a microscopic tendon. There are changes in cellular structure in the first stage. The tenocytes become parallel, cell nuclei become rounded, and tenocytes lose their fine shape. This is called fibrocartilaginous metaplasia. When there are intrinsic factors, such as dyslipidemia, genetic factors, hypermobility, overweight, and too many, or extrinsic factors, such as the use of corticosteroids, statins, previous ligament injuries, consumption of quinolones, or poor sports technique, we move on to phase 2, where the tendon healing process fails. Existing in this stage, we have disorders of tenocytes, proliferation, degeneration of the tendon cells, disruption of the collagen fibers, an increase in non-collagenous matrix. This is now when we reach to phase 3, where the clinical manifestation appear with failure to bear loads and the appearance of pain producing mechanical failure, like this example. Canut et al. Demonstrated the existence of degenerative chains in 97% of Achilles ruptures. But we must not forget that pain, all the pain in the general of tendinopathies, is caused by a complex system of altered neurotransmitters, even at the level of the central nervous system, like increase of glutamate or increase of substance P, the histamine and noradrenaline. The patellar tendinopathy is the second most common tendinopathy. The first one is the Achilles tendinopathy. The patellar tendinopathy is the first cause of pain in the anterior region of the knee in high-performance athletes. Progressive limitation of function appears with a variable pain according to degree of affectation and time of evolution in each tendinopathy, and is difficult to recover with a reserved prognosis in chronic cases. Histological, it's a degenerative process. It's epoxic, hyaline, mucoid or myxoid, fibrinoid, lipid, calcifying, and with a fibrocartilaginous metaplasia. All cells in this tendinopathy changed, like collagen, tenocytes, and the extracellular matrix changed the shapes, changed the function. That's just the reason, because it's very, very, very important. And the collagen fibers, the collagen fibers are lose their parallel orientation, decrease in diameter and density, and type 3 of collagen increase, failure to perform its function. But on physical examination, the Bassett maneuver with knee extension is a positive, and the pain might disappear with the knee is in flexion. It's important to evaluate the state of extensor system and the range of mobility with like dynamic gestures like that. It's important to think in a differential diagnosis like Cinder-Larsen-Johansen in younger patients, like Osgood-Slater too, the patellar chondromalacia, patellar bursitis, medial synovial plica, meniscopathy or rupture, total or partial tear of tendon is very important. And we use the Blasina scale, which is based on the patient's pain when performing physical activities. In the first stage is no pain, and the stage 4 is when the function is totally altered because the tendon rupture secondary to chronic tendinopathy. And also these scales that allow us a clinical classification based on symptoms, severity, functional capacity, and sports performance. As a method of initial diagnosis, ultrasound has shown safety in 12 diagnoses compared to MRI, allowing to see details of the bed's quality in patellar tendon compared with MRI. And with the new device of ultrasound, we can see all of the details of these tendinopathies, as well as the neovascularization scale, in which grade 0 doesn't show flows. In the grade 1, vascular flow is visible only near the tendon. Grade 2 is the presence of 1 or 2 vessels in the patellar tendon, and the much higher grade is the 3, the presence of 3 or more vessels in the patellar tendon, like this video. But the MRI is used only for chronic cases, localization with a greater precision, identification of concomitant injuries, does not serve as a prognosis. There are not immediate changes with any treatment. But what can be done? The first stage is a non-invasive treatment like physiotherapy or minimal invasive treatment. In this stage, enter the biological treatments, or in some complicated cases, a surgical treatment. There are many reviews on possible treatments in tendinopathy, such as biophysical stimulation, bioactive agents, cell therapy, scaffold implantations, or surgical approaches to tendon injuries. Therefore, the rehabilitation is a cornerstone of 3 phases of treatment. In stage 1, the pain modulation and the load management. The stage 2, strengthening, exercise, and load progression. And the stage 3, the functional strengthening and return to sport. The best current therapeutic alternative is the use of shockwaves. And there is important to say there is no major difference in the therapy with radial pressure waves and the focal shock waves in different studies. The way we apply shock waves is with the patient in supine position with the knee flexed. In this review, the authors recommend the use of shock waves in chronic tendinopathy or when the conservative treatments have failed. Use of anesthesia is not recommended. It should be kept at least 2 weeks at relative rest after shock waves. Working with eccentric exercise shows better results than with shockwaves alone. 3 to 5 sessions, 1 per week, are necessary to achieve a complete treatment. And this is the suggested protocol for shockwave types, the radial shockwaves and focused shockwaves. This was, or the shockwaves demonstrated in this meta-analysis by Liao, which concludes this study obtains a moderate evidence that general shockwaves significantly increase treatment success rate, reduce pain, and improves functional recovery in patients with knee tendinopathy. Based on meta-analysis, both shockwaves therapies are worth considering in the treatment of soft tissue disorders, particularly in this patellar tendinopathy. But be careful. We have started to have complications due to poor application and ignorance of this technology in case of chronic tendinopathies, where it is observed like this case. Tendon tears and difficult in tear resolutions. Therefore, we recommend reading of this review article, which was on ONLAT before, detailing the complications and poor results with shockwaves. We had worked together or after the application of shockwaves with a high volume image guide injection, which has been shown to be complementary method to improve the function and pathology of chronic patellar tendinopathies. Some examples of this technique, the objective of this technique is to dissect the space between the tendon and the space between the tendon and the HOFA fat, eliminated the pathological blood vessels. With more flow of fluid, we can cut the pathological blood vessels. But there are several effective alternatives for these pathologies, such as open and arthroscopic surgical treatments, medication, high-intensity laser, and also biological treatments with a PRP or stem cells. The success is achieved with an accurate knowledge of the pathology, proper use of technique, ultrasound guide in the modes treatment, and the most important is a teamwork. Thank you very much for your attention.
Thank you very much, Paul. Very clear. It is a very multifactorial conditions, so we need to check many factors when dealing with this. Now we will move to Dr. Leonardo Guilov from Chile. He will speak about laser therapy. That is a new tool that he's developing. Leonardo.
Yes, you can see me?
We can see you and we can see your screen.
Okay, I would like to change. Thank you very much. I don't have any conflict of interest either. And thank you very much for this invitation and for people from India that are also hearing us. I'm going to talk about another type of energy, physical energy that we are using very commonly in this type of pathologies. And let me introduce this technique of the high-intensity laser therapy in this scene. I put this in because that demanding young girl that you see in the escalator have had a degenerative and also self-limited and also non-inflammatory problem in the elbow that we but call epicondylitis, because the problem of this tennis elbow is something more degenerative than inflammatory, but this is a self-limited overuse disease. She has been seen by this doctor this doctor has indicated not anti-inflammatory drugs, and afterwards physiotherapy. That is very common in the first stage of this pathology. As Dr. Teran told us, we have stages in the tendinopathy. But even though she has continued with the pain, and she asked the doctor what to do. And it's very common that doctors, especially young doctors, has in his head to go immediately to something to cut the pain, such as a corticoid injection. And we all know that that is not only a very limited good result, but also we know nowadays by different papers that the corticosteroids are toxic to the cells. So we can have a new pathology again, but worse because of this use. But when they fail with that, they are thinking in open surgery or arthroscopic surgery to release the tendon, in this case, the extensor tendon, to have less overuse. And they forget, at my point of view, that's why I'm telling this, my experience, I have 30 years doing this, that they forget that we have now regenerative medicine. And in regenerative medicine, we have steps that we have to go, such as in this escalator. And the first step that is tools that are physical stimuli to the cell that produce response and healing to this, in my experience, is one of the most effective in 99% of the cases, such as this or another cases that I will show, that prevent to go to the second step, that is semi-invasive regenerative medicine with infiltration, like PRP or another, that you can use it also. There are papers that demonstrate good result. And the last step can be the invasive regenerative medicine. In some cases, not in this tendinopathy of the elbow, but in others, you can use scaffolds or mesenchymal stem cells. So what I think that we have to go to the first step that I told you, because there are a lot of papers such as this, Silver, that demonstrate that physical waves like pressure, electric waves, photons, vibration, stimulate cell membrane, produce protein synthesis, cell mitosis, and also can alter the gene expression, changing the cell to produce the healing. In this presentation, I want to talk about photons. We are hearing in the other presentations about pressure. Now I'm going to talk about photons. That we all know that sun with heliotherapy has been a very good tool since the antiquity, and people use this, putting some wounds at the sun to have more effective healing. And after that, man has used this, organizing better the photons in polarized light therapy, and nowadays with the laser therapy. Laser was described by Einstein in 1917, and Mester used this first in wounds in medicine in 1976. What is laser? Is a light amplification of stimulate emission of radiation. We use in the electromagnetic wave field the waves that are in between 700 and 400 nanometers of length in between the waves, that are the one we have in the color, in the visible colors. And also we can use infrared in some cases, such as I am using today. This is polarized and coherent photons pointed to a place. In 1960, the first surgery was done with the high-intensity laser therapy, that is a concentrated laser that can make fulguration and healing. And nowadays, the high-intensity laser therapy that is called type 4 is decollimated, opened, so we don't burn anything. We are following with this method to have better healing. And low energy fount of producer of the laser is only capable to go inside the skin. So in this type of laser, we only use in wounds or on superficial lesions. But when you have more power in your fount of production of the laser, you can go inside until including bone. That's why there are a lot of indications. Nowadays, I'm going to speak about upper extremity, but you can see here that a lot of indications for bursitis, synovitis, trigger points, epicondylopathy, even lumbar pain. Osteoarthritis is very important. I have a large experience doing this in osteoarthritis, degenerative osteoarthritis of the knee that I will present in the next Congress in Spain, scars, wounds, etc. The literature in upper extremity, we have a lot of papers with good results, such as this, that laser therapy in frozen shoulder, epicondylitis also, as you see here, and also as you see in the other slide, in musculoskeletal disorders, and in subacromial impingement also. But I will stop in two papers that I feel that are very good because they demonstrate something that I'm seeing in the clinic every day. This first paper is about the gene expression of the chondrocyte that the laser can produce more stability in the chondrocytes when they're in the process of the aging. And also you can see that if you apply comparing in a control group laser in a cartilage, the extracellular matrix can produce more collagen 2, that is the most important collagen in the cartilage cell. So with that type of physics stimuli, you can have more stabilization and more extracellular matrix in the cartilage that you can see that in clinic when you treat degenerative arthritis of any joint. And this paper is very, very important. This paper was done in mesenchymal stem cells in equine bone marrow derived mesenchymal stem cells to demonstrate that this type of stimuli in the cell can produce a regulation of the cytokine expression in the inflammatory process in an injury tissue or an ill tissue. This paper make to me take to me to do in human something similar to see if all that studies was true. And we, with medical engineering that is now working, she's from Austria, now she's working in Chile, Dr. Cristina Schuh and me, decided to treat with this system stem cells in vitro in two experiments. The first one was to see if the cell, if you apply, comparing with a control group in these stem cells, laser, you can have more migration, also more proliferation. And in the last study we did was to demonstrate if was really this great capacity of this laser to produce anti-inflammatory effects. And first, what we do, we put these mesenchymal stem cells in flasks and put, as you see there, the energy. We use the same device that we use in clinic. We did a scratch with a pipette in the middle of the flasks where the cells were, and we measured this 24 hours later, and we could see that in the laser group, the scratch was completely closed, and in the other, continue open. So we see as you see in the graphic, that we have more migration. Afterwards, we put the cells in these well plates, 96 well plates, and we apply the fetal bovine serum, that is something to make the culture medium to proliferate. And what we saw at 24 24 hours, is that in the control group, the proliferation was less than in the laser group. And the last experiment we did that is the most important is we tried to see in cells treated with LPS. LPS is a lipopolysaccharide that is taken up from the membrane, the outside membrane of the gram-negative bacteria. And it's very, very irritative for the cells. And we put this irritative in some of our flasks and in the other not. And what we see in conclusion is that in the supernatant, when we apply this irritative in the cell, and we apply laser, we have the more, as you see in prostaglandin 2 and interleukin-6, the more elimination of these pro-inflammatory cytokines in vitro when we do this. And that can explain to me why, when we are trying some zones with a very big inflammation, if you apply laser, you can have a great response of anti-inflammation. In this slide, I say the same, so I'm going to be quicker. We have nowadays, and Dr. Moya is one of the most important people that can, with also people of India, that can done the first regenerative science journal. And I could explain this if you are interested. You can go to the first number of this, and I explain the same and with more details of this type of research in this first number. Now I'm going to present a clinic study that we are doing in multicenter here in Chile in adhesive capsulitis. This is the experience of this doctor that is working with me in this type of pathology. In this study, he presented us in a webinar that have done some time ago. We studied 10 patients that with exclusion criteria, as you can see here, have adhesive capsulitis. We use this protocol, one protocol in analgesia and another in biostimulation, as you can see, 2 sessions a week. And we measure with the test of UCLA the rigidity and the function of the shoulder. And we can see that in 9 cases, we have good and regular results, excellent, none in nothing, but only 1 bad case. And the most important thing is that not only the movement and the function was improved, but also pain. Here in red is when they begin, and here in green, when they have finished this study, they have less pain. I want to show you some special cases that I have had in my life. This is one of them that is very interesting because it's not only a frozen shoulder, it's also a shoulder that have a partial tear that we wanted to solve because the pain of this patient was terrible. Here is the patient. You have here some partial tear in the rotator cuff. She have had some months before an accident. She was 65 years old, and she came to us with an adhesive capsulitis phase 2 with 10 of pain in the VAA scale. It was a terrible pain. We could even not move it, and we wanted to heal the tendon and also to try to treat the frozen shoulder. What we did, we put this patient in sedation. And in the moment of the sedation with physiotherapists, we started to move this and obtain in the tendon remission of the partial cuff, the partial tear. We put shockwaves in the common use that we do it for this type of patients of this type of tendinopathy with rupture. After that, and the following day that we know that the patient will have also stiff of the elbow, we continue with the protocol of laser and movement immediately. After some days, we start with the third phase of rehabilitation treatment, and you will see that this patient, after 1.5 months with that terrible pain and with stiff, completely stiff of the shoulder, we have not pain, only some pain in the movement, and we didn't use not analgesics, not corticosteroids, and this woman recovered completely. So this is a special case that we can use both technologies, laser and shock waves together. And the last case is a very interesting case. When you have a calcific tendinopathy, and you are, and this is a self-limited also pathology, and the pathology is starting to have the removing of the calcium by reabsorption, you never have to apply something that produce more irritation, such as shock waves. You have to wait that and put some type of method that don't produce more pain and can help to the patient that this self-limited reabsorption would occur. What we did in this 53 years old woman that is a physiotherapist, and I will show you in a video, is in this case that she has a Gardner 3 calcification. It was starting the reabsorption. We decided not to use shock waves at all. It's not indicated, but we use, as you will see, high intensity laser therapy. Here we show you, here is the calcification grade 3. Here is the patient with a lot of problems with the movement. 5 sessions of high intensity laser therapy, and 6 weeks later, the pain was gone. QSLA has in the maximum, and you can see the woman moving the shoulder completely without pain. Here is the first, and here is the last, the post-treatment use of high intensity laser therapy. So in this, that is a very pro-inflammatory problem, you have to use something for the inflammation more than the reabsorption. So in conclusion, frozen shoulder and rotator cuff calcified tendinopathy type 3 are self-limited pathologies. Even so, frozen shoulder have a very slow improvement with manual therapy, and in significant number of cases, you need to use corticosteroids. I don't use it today, never. And in calcific tendinopathy, needle puncture also, like to clean the calcium from ARSA, like the barbotage, when the reabsorption has departed because the pain of these patients are disabled. With high intensity laser therapy in my hands, both problems were solved by decreasing the rehabilitation in frozen shoulder without any type of anti-inflammatory drugs or corticosteroids, and also producing a rapid relief of pain in calcified bursitis in the absorption phase, avoiding any type of invasive procedure. As other presenters said, we are going to be very soon in Spain. I hope everybody of you can go to Madrid. I think it would be a very good Congress. You can see some presentation by Zoom, but other in presential. So I invite everybody to go there. Dr. Karen Freytag have done a lot of effort to do this, and we hope everybody will be in expectation of it. Thank you very much for hearing, and excuse me the long presentation.
Thank you very much, Leonardo. It was a very clear and complete presentation. Now we will go ahead with Dr. Edson Serrano, who will speak about the use of shockwaves in the treatment of a vascular necrosis.
Can you hear me?
Yes.
Absolutely. Well.
Thank you, Daniel. Can you hear my presentation? Can you see?
You can see it, yes.
It's changing? It's changing,
Yes.
no?
Yeah.
Thank you. Thank you very much for the invitation. I'm very happy to stay with you to share a very interesting topic this morning. My name is Edson Serrano. I am orthopedic surgeon, and today I will talk about alternative of treatments for osteonecrosis of femoral head. First, we have to the definition of the avascular necrosis is disruption of circulation of the femoral head. The death of the bone can produce joint degeneration. This pathology is approximately produced in 1 per 1,000 people between 25 to 45 years, averaging 38, and is responsible of 5 to 20% of total hip replacements in USA. Is very common. The cause of physiopathology of these illnesses could be traumatic pathway or non-traumatic pathway. The traumatic pathway is related with hip dislocation or proximal femoral fracture. These conditions produce vascular disruption and critical ischemia and produce necrosis. In non-traumatic pathway, is another conditions that states hypercoagulable conditions in the body, that these conditions produce thrombus formation and critical ischemia. The most frequent non-traumatic etiology is steroid-induced. Approximately 25 to 50% of necrosis could be produced for steroid-induced. Alcoholism is another risk factor, and another illnesses like sickle cell anemia, decompression disease, Gaucher, syndrome antiphospholipids, lupus, tumors, radiation, and approximately 25% of these pathologies we don't know why these are idiopathic. When 3 to 25 of patients treated with steroids developed osteonecrosis. That depends of dose of these steroids. More than 20 milligrams per day of prednisone is more risk to develop this condition. The initial dose is very important to develop this condition. The diagnosis is performed by clinical evaluation and some images. In some cases, it could be necessary to do another exams like PCR, rheumatoid, autoimmunity, etc. But the main, in the most cases, the clinical evaluation with X-ray or MRI is the diagnosis could be done. X-ray is the first imaging sensitivity in early stage is 41%. Is very low. For this reason, we don't use to perform the diagnosis in early stages. But in later stages, we can see flattening, collapse, and degenerative changes in hip joint. TC scan can show us morphology, extension of injury of subchondral bone, but sensitivity is in early stage is very low to 55%. MRI is the gold standard image to perform diagnosis, and sensitivity and specificity is 99%, especially in pre-collapse injury. We can see typical images of in MRI to perform if he always we can search in another hip, because approximately 50 to 70% could be bilaterality. There are many classifications. Ficati-Arlet was one, Steinberg, and ARCO is the most important and most used in this moment. This ARCO classification is reviewed in 2019, classified in 4 stages. 1 and 2 stages don't have collapse. In stage 3, we have subchondral fracture. If we have femoral head depression less than 2 millimeters, is 3A, and more than 2 millimeters of depression femoral head is 3B. In ARCO 4 is evidence of osteoarthritis, joint space narrowing, and degenerative acetabular change. About the treatment, this article is very interesting. I recommend this. This was published in 2020. And we have non-operative treatment for this. We have observation, weight-bearing restriction, bisphosphonates, anticoagulants, vasodilators, aspirin, extracorporeal shockwave therapy, pulse electromagnetic fields, hyperbaric oxygen. All of these treatments, non-operative treatments, are have grade of recommendations high, because don't have enough scientific evidence in the literature. But in forward, we can see a little more about this. Extracorporeal shockwave treatment, you can see in this article published by C. et al. And Algarni. We can see hip survivor in the right side, 81 to 95% of hip survivor in pre-collapse. We can see all of these treatments, non-operative treatments, are indicated in pre-collapse stage. Operative treatments are recommended in pre-collapse stage and post-collapse stage 2. We can resume core decompression, multiple small diameter drilling, cell-based therapy, non-invasive bone grafting, vascularized bone grafting, osteotomies, and in post-collapse stage is recommended total hip arthroplasty with rate of recommendation A. Core decompression is most widely used, decrease elevate head pressure, improving pain. The failure rates is 5% in medial lesions. More failure rates is in large lesions, like you can see in this publication that by Leverman. Okay. Core decompression can is a joint preservation surgery, improve blood flow, decrease intraosseous pressure, and is indicated in pre-collapse phase. Core decompression can show us only core decompression can show us survival of the hip head, approximately 87 to 86% of survival in follow-up of these studies. What we can do after drilling, after core decompression, we can perform vascularized bone graft, non-vascularized bone graft, or autologous bone marrow. mesenchymal stem cells. There are many articles about this, but in creeping substitution, in this stage, we can induce the revascularization of the bone doing core decompression and putting some kind of graft, maybe vascularizate, not vascularizate, or bone marrow concentration. Core decompression muscle therapy, the study most important for, in my opinion, is the Hernew and et al. Published in 2018, indicating pre-collapse bone marrow, and it was compared with only core decompression, and the results are much better in core decompression plus bone marrow mesenchymal cells in compare only with core decompression. New techniques like stem cells, BPM or Tantalus rods don't have enough evidence to recommend it. Bone graft don't have a very rare, very high of rate of evidence. In non-operative treatment, we have the shockwaves. The shockwaves are mechanical waves to put in the skin, and these waves pass through the tissue until bone. In this mechanical stimuli in the acts in the cellular membrane and induce cellular response. This response is producing different substances that can improve the circulation in the bone, can produce osteogenesis, and produce many kinds of molecules like plated endothelial cell adhesion or another cells. In conclusion, that produce increase of vascularization in the bone and increase of osteogenesis, like this study. There are many papers talking about this. I am showing some of these papers. This Italian experience for this. In this systematic review, extracorporeal shockwave therapy in osteonecrosis of femoral head, reviewed in total 17 articles, and the conclusion is the shockwaves is safe and effective method to improve the motor function and relieve the pain in patients with osteonecrosis of femoral hip. I think this is the one of the most important paper that confirms that the shockwaves is very and very effective. This paper was published in 2012 by one, and in this study analyzed long-term outcomes of extracorporeal shockwave therapy and core decompression for early osteonecrosis of femoral head with 7 to 9 years old of follow-up. In this study, includes 48 patients with 57 hips, including 23 patients with 29 hips in the extracorporeal shockwaves and 25 patients with 28 hips in surgical groups. The objective of this study is compare the treatment with extracorporeal shockwave treatment and core decompression, and follow up 8 to 9 years old. 23 patients, extracorporeal shockwave with 29 hips, 25 patients with 28 hips, core decompression. The groups are very similar. You can see the demographic characteristics of the patients are very similar. Number of hips, average gender, size, duration of symptoms, all are very compared groups in shockwaves and surgical group. In results, we can see the hip survival. First, we can see in wave group, the survival of the hips are 22 of 29. Number of total hip arthroplasty is 24. In compare, in surgical surgical group in core decompression, the number of the total hip arthroplasty are 64%. It's very clear in the shockwave groups is have better results to survival. The same results in pain is better results in shockwave groups. You can see the follow-up 8 to 9 years old. The pain score is less in compared to surgical group. The same results in Harris hip score. Best results for shockwave groups. Sites of lesion is similar. Sites of lesion in the shockwave groups are lesser than surgical group. You can see the imaging resonance in the right hip before extracorporeal shockwaves at 6, 12, 24, and 36 months after treatment. You can see the evolution in MRI and X-ray. In shockwave groups don't have complications. In surgical groups have morbidity of donor of average of 58%. In conclusion, the extracorporeal shockwaves is more effective than core decompression and bone grafting in femoral head. But there are many controversial results. In some papers have very good results, in another don't have very good results. What type of waves we have to do? High energy equipments, electrohydraulic equipments. I will show some cases. Case 1 is 38 years old, male, pain in both hips. 1 year after, in the right side, in the left side, it's 1 year is after 1 year is another in the right side radiography, X-ray. We performed this treatment 8 years before. And you can see the MRI. You can see the stage 3 or 4. We perform core decompression, shock waves, and this patient had a very clear change of joint degeneration, but have 8 years of follow-up, but don't want to perform total hip replacements too. Another cases is male, 43 years old, bilateral, reduced. You can see the stage 3. Same, we perform core decompression, shock waves to improve results. This patient had 1 year after Until now, we have 2 years of follow-up. Have a little pain, but he don't want to perform total hip replacements too. Another case, male 33. You can see the severe change in the right hip. To this hip, we decide to perform total hip replacement, and in the left have femoral acetabular impingement. We perform shockwave, hip arthroscopy, and bone marrow cells, and core decompression and shockwave. This is the final of these patients. In the right hip, have total hip replacement. In the left hip, we are dilating for the total hip replacement, but we are waiting because it's very young patient. Conclusion: if we have hip or groin pain in young adult patients suspecting osteonecrosis, it's very important to perform early diagnosis. For this reason, that depends on the results. Always thinks in bilaterality. Shockwaves are safe and effective. The evidence for cell therapy is increasing. In pre-collapse stage, we combine core decompression and shockwaves. And post-collapse, we think in another techniques and maybe in total hip replacement. Young patients try to delay arthroplasty. Thank you very much.
Thank you, Edson. This is a very interesting indication. And we will finish talking about a very frequent reason for the patients to get in touch with us, that is lateral elbow pain. Do you know that we define this as the presence of pain over the lateral epicondyle of the humerus during loading of the wrist extensor muscles? And it is common between 1 to 3% of the general population, generally at the middle ages. And there are some activities that increase risk, like smoking, doing manual work, or playing tennis. It is clear that this is a disbalance in the quality of regeneration of every tendon, and Dr. Terán was very clear talking about this. We know that the inflammation could appear at the beginning of the process or as a collateral situation related to the degeneration, but it is not the main problem. We know that there are changes that include vascular, chemical, and cellular degeneration, and this is the main reason for the chronic tendinopathies. In this case, they are located in the insertion of the extensors of the wrists and fingers, and the pathophysiology is related with several features. If we speak about genetics, there are some patients that have a tendency to have mesenchymal problems, and this is called mesenchymal syndrome. And generally, we see in those patients rotator cuff tears, epicondylopathies, carpal tunnel syndrome, and Decarbon disease. It has been related with some types of blood, like zero. So we need to be aware of that. Some authors have even go forward and talk about the new integrative model of lateral epicondylalgia, in which the tendon itself, of course, is very important, and the changes that the tendon suffer, but there are changes in the pain system, in the way that patients are able to recognize and feel pain, and also in motor systems, like alterations of corticospinal control and the way that we move our upper limb. So it is not our classical point of view, but now when we speak about tennis elbow, we must also consider that it is a nervous system mediated phenomenon. It is related with physical functioning and even with psychological factors. For instance, it has been described that patients who suffer epicondylopathy have, for instance, a level of tolerance of cold that is lower than the average of the population. So the pain perception is different in these patients. You all know the tests that we use to recognize this pathology. And of course, there are images. Sometimes we can see calcifications in the area of the tendons, as we see here. But ultrasound is a very informative technique in which we could see a thickening of the extensor tendons, the presence of microcalcifications, ruptures that can be small, but in some other cases are big ruptures. And even with the Doppler effect, we can evaluate the alteration of the vascularization. MRI is also useful. We also see areas of inflammation in some cases, thickening of the tendon, and even the rupture, as I said before. We know that in many cases, ultrasound and MRI are showing changes that are not related with symptoms. And this is very common in this type of pathology. Some studies have evaluated the contralateral elbow and have seen the same changes in an elbow that is asymptomatic than in the symptomatic elbow. So of course, we must always put the information bring by the images in a context and considering patient's symptoms. We have a long list of differential diagnosis, beginning with pain coming from the cervical spine, but we also know that patients with problems in their elbows have in average a higher level of neck pain than the general population. And perhaps this could be related to that lower threshold to refer pain or to feel pain. There are other situations that should be ruled out, like the presence of loose bodies, osteochondritis, dissecans. That is very I have seen patients like this, and the symptoms are very similar to the ones of the lateral elbow. Plicas have been controversial for some authors. They have a very important role in the physiopathology of these symptoms, and for others, they are just something that we found and they are not related. But if we rule out all the other pathologies, all the other reasons for pain, and we treat conservatively the patient and we do not see response, perhaps it is important to go ahead with a resection of these plicas. Elbow posterolateral impingement is very common in throwing sports and should be considered. And we can also consider elbow instability. There is an association between shoulder pain in the area of the epicondyle and instability, because the lateral ligament is fused in some areas with the tendons, the proximal insertion of the extensor tendons. There is a very close anatomical relationship between these structures, and we must consider this. A very sometimes very difficult differential diagnosis is the radial tunnel syndrome. It is an entity that was even denied by some authors, and it is considered a compressive neuropathy of the posterior interosseous nerve. It is more common in ladies in the middle ages, and these patients refer a very important pain. EMGs are not completely clear about this pathology. It is more common in the dominant side, and in many cases there is a history of shoulder pathology, carpal tunnel, and Decarbon disease. Generally, the pain is aggravated during night, and many patients refer arm fatigue. The area in which the pain is localized is generally distal to the typical area of pain of the tennis elbow, and generally the tests cannot be very clear for this. It has been described this test in which the proximal forearm in its ventral aspect is divided in 9 different areas. Each area has the size of a $1/4 coin, and it is considered that if the pain is located in the areas 1 and 2, it is a typical localization of pain related to the radial tunnel syndrome. In the blue areas, there is no relation, and in the areas 5 and 6 in yellow, generally the reason for pain is the compression of the proximal median nerve. There are some tests related to neurodynamic. That is an approach that is developing fast in the last years. And the maneuver to recognize pain coming from the compression of the interosseous posterior interosseous nerve is as you see in this picture. The wrist should be put in flexion, in very extreme flexion, and hyperextension of the elbow. And in this position, we ask the patient to flex his neck, and generally there is an increase of the symptoms. In that case, it is considered that there is really a compression of the nerve. But as you see, is a very subjective and not completely exact procedure. MRIs can show indirectly some changes related to the compression, like edema of the nerves, of the muscles, but we have found that ultrasound of the posterior interosseous nerve is very useful. In this case, you can see comparing the normal side with the affected side, and as you see, the nerve in the area, in the side that is affected with the presence of symptoms is almost 2 times the size of the nerve on the contralateral side. When we talk about the treatment of elbow pain, we must consider in these cases that prevention is very important, and to reduce repetitive load volume, improve musculoskeletal base, and improve sports skills, especially in those who play tennis. It is very important. The sport should be adapted to the patient and not the patient to the sport, and sometimes these generates problems and is difficult to deal with. It is important also to eliminate acquired risk factors, like, for instance, smoking. Some authors propose a wait and see policy because they consider that this is a self-limited disease, and rest and education should be useful. But the problem is that this way not always lead to a complete resolution, that up to a third of patients have prolonged discomfort, and there is a high recurrence rate, especially in those who practice sports. It is very difficult in our society, in our modern society, to make some people realize that they are not young anymore and that the quality of their tissues is not the same as some years ago. And for some people, it's difficult to adapt, to get adapted to a new rhythm. But I think it's very important to talk about that. We know that some prognostic factors can give us an idea of what will happen in the future. For instance, if we have a tendon rupture, of course, the prognosis is not as good as if the tendon is in good condition. It is correlation between the severity of pain and disability and the prognosis. Central sensitization, like for instance, as I said, lower threshold to pain in general will give us a worse prognosis. The presence of associated musculoskeletal comorbidities, as we said, perhaps the patient is not having just a problem in his shoulder, but also having some other problems, and making us think about a mesenchymal syndrome. Also associated neuromuscular impairments, patients who have a alteration of the corticospinal control will have a worse prognosis. And finally, as you all know, work-related problems and psychosocial factors will make our prognosis worse. Many different treatments have been proposed for treating this condition, but the problem we have is that there is no conclusive evidence for any one of them, including surgery. The pharmacotherapy has conflicting evidence and secondary problems, and the corticosteroids, it was said, for instance, speaking about plantar fasciitis, also provides short-term relief, but not for a long time. Some authors have proposed the use of antidepressant or anti-epileptic drugs with good results, and this would work in those with central sensitization. Manual therapy has a moderate evidence in the literature. We all use stretching and strengthening of the muscles, and that's a very good indication. The use of braces, even though has not a very strong, a very solid scientific evidence, is very useful for many patients. So we use strap for epicondylopathy, and even we have seen that there are some techniques like taping that have been communicated as useful, but there is still not a strong evidence. Prp injections have been controversial, but it seems that related to shoulder pathology, to elbow, pathology, some authors have good results and can be an option once non-invasive techniques have been ruled out. There were some other treatments like the use of nitric oxide, polydocanol injections, looking for sclerosing the aberrant vessels, but they are not frequently used. What about shockwaves? Well, there are good results that have been published both for radial pressure waves and for focus waves, for extracorporeal focus waves. But they do not have the first level of evidence, a grade of recommendation A, as in, for instance, pathologies like calcifications of the rotator cuff or plantar fasciitis. They have a grade of recommendation B because they are papers communicating good results, but we do not have yet enough number of level of 1 or meta-analysis papers supporting this. Even though that this is a review that was published by Thiele in 2015, and they made an analysis of the evidence in the literature, and they saw that most of the papers having results that were not completely good were published till 2002. And after that, related perhaps to the quality of the devices or the techniques, the results, the good results are more uniform. This is level 1 paper published in the Journal of Bone and Joint Surgery that shown the presence of good results and significant results with the use of shockwaves. This is another paper comparing shockwave, focused shockwave with percutaneous tenotomy in resistant tennis elbow, and the clinical results were similar after both procedures. Of course, if shockwaves do not give good results, and we do not have good results, for instance, using PRP, surgery is the option. There are open techniques and arthroscopic techniques, the combination of both. This is the treatment algorithm that we propose. The first step is rest, rehab, the use of painkillers. We can use ice according to the patient reaction and the patient experience with it, exercises, and brace. If it doesn't work, the second option would be the use of radial pressure waves or focused shock waves plus exercises. Exercises are essential always. And if not, needling or the use of PRP. I am not sure if PRP is working because of its biological effect or because of needling. We know that there are some authors that are advocating that the prolotherapy is useful. So it would be interesting to discuss and compare that in some studies. And if it is not working with these techniques, the next step would be surgery. Fortunately, most of the patients have a good result with the first and the second step, and it's not common for us even to go to the third step. But we shouldn't put the patients in risk and use invasive methods if we have not completely considered the results of the non-invasive methods. Thank you very much. That was my talk. So I think Dr. Ashok, Dr. Niraj, that this was our message. Perhaps we do not have the option to make questions or discussion as this is record, but if you want to ask something, you will be welcome. Dr. Ashok?
Yes.
We are ready. Everything was presented, so we need to close now the session.
Sure. No, I think it was an excellent webinar, especially because this area of research and this area of specialty is very less known in Asia Pacific region. especially in Indian subcontinent, it is still in very nascent stage. And I'm sure this webinar, these presentations will really impact the viewers in my country, especially in my country and in my continent also. So I'd like to thank each and every one of you for participating here. And this is the part of Wiroc Global webinar series where more than 70 societies are participating. So members of all those societies will watch this and will get insights into Shockwaves and how this team of expert has been working, putting in a lot of hard work and effort in developing this field. So I'm sure your research and your work will get a lot of exposure and a lot of people will be benefited. A lot of patients will be helped by this webinar. Thank you very much for participating and helping us. Thanks a lot.
Thank you very much, Ashok. Our pleasure.
Thanks a lot.
Thank you very much.
Thank you for you.
Thank you very much.
Thank you.
Thank you very much,
for
everyone.
everybody.
So we are offline now. So